So a very hope I'm audible for you all. Sorry for the interruption. Yeah. So a very good evening, everyone. Welcome to another live session. So as you all might be knowing, today we are specifically talking about two particular topics from Perio. So if I talk in terms of the relevance of these topics from the examination point of view, uh, I was going through the various PSC papers, and what I could decode was the subject perio altogether has a weightage of around 4 to 8 questions in the PSC examinations. That is, you can expect 4 to 8 questions from perio itself. And in that, there is hardly any paper without at least one question from the topic necrotizing ulcerative gingivitis or periodontitis. Okay, so that is one of the topics of discussion for today. So there lies the significance of that topic also. So this particular topic, fortunately, it's a very easy topic. Like it is easy to be read and understood, and also it is easy for you to recollect what you have read also. So I don't want any of you to lose any marks if a question comes from this particular topic. You can expect 1 to 2 or maybe more than that questions from this particular topic. And with regard to the second topic, that was splinting, uh, frankly speaking, there are no much questions that has been asked until now, but there is always in every examination, there is always a particular part. What is that? It is always we should expect the unexpected. So splinting can be categorized in that part where you can expect maybe like an unexpected question can come from the portion. So you shouldn't skip through that too. So I hope this session would benefit you all. So without any further intro, let us move to the session. If you have any doubts, you can just chat, give in the chat box. And also, there are some multiple, I mean, this MCQ questions which I have included in this PPT. So those who of you who know the answer to that can give in their answers in the comment box. Okay. So first is necrotizing ulcerative gingivitis or periodontitis. So earlier, this was called as ANUG, that is acute necrotizing ulcerative gingivitis or acute necrotizing ulcerative periodontitis. But now the terminology has been, that word acute has been removed and just we call it as NUG or necrotizing ulcerative periodontitis. Why? Because this particular condition, it is an acute gingival infection. Okay. There is no chronic form in this particular disease. Okay. So this terminology acute is actually a misnomer. Okay. Since there is no chronic form for this particular condition. That is why that terminology has been called as a misnomer. And so when you discuss, like when we discuss about NF or this necrotizing form of periodontitis, there are certain other lesions much similar in their clinical presentation, which we have to just brush through. Okay. So herpetic gingival stomatitis is one such lesion. And also there is yet another, which is the squamatic gingivitis, which also we will be covering when you cover this particular portion. Okay. So the first question. In Horning and Cohen staging of acute necrotizing ulcerative gingivitis, the clinical findings seen in stage 4 is. So there are options. You can read the options from the screen. So from this particular question, you can gain so much of knowledge. Like you can get to know that there are different stages in which this particular infection progresses. Okay, like so you should know the staging, like how it progresses and in what all stages it progresses. And Horning and Cohen is the one who has given out the stages. So the answer for this, for those of whom know, can answer in the comment box. But for the time constraints, I'm proceeding with the slides. The answer to this is stage 4 is necrosis extending to attached gingiva. So you should be well thorough with the different stages in which this infection progresses. Okay. And next question is, recently diagnosed HIV positive patient with CD4 cell count less than 160 cells per millimeter cube to clinic with presented to the clinic with ulceration and bleeding from gingiva. So what is the diagnosis? So in this question, it is very clear that the patient is HIV positive. And from the CD4 cell count, it is clear that the patient is immunocompromised. Otherwise, itself, these HIV patients are immunocompromised because of their lower cell count. Okay. So now what you need to know is what are the gingival manifestations or the periodontal manifestations in an HIV patient? Okay. So there are two. What are they? ANUG or necrotizing ulcerative periodontitis and also linear gingival erythema. So in these options, among the options, what you have, among the what I told you, the two of the things which I told you, the option NEG is there, or necrotizing ulcerative periodontitis. So it is, of course, the answer for the question. Okay. I hope that question and answer is clear to you all. So now we'll deal the theory part of necrotizing ulcerative gingivitis. Okay. So the causative agent. So this is an infection. This is caused by bacteria. Actually, it is caused by a symbiotic association of two bacteria. What do you mean by symbiotic association? That means two bacteria, they mutually benefit from each other for their growth. So this is a symbiotic association of Borrelia vincenti, which is spirochete, which is a motile organism, and fusobacteria. So it is also called as spirochetosis. And since these are motile organisms, this can be identified by dark field microscopy. And this particular condition is also called as an opportunistic infection. Why? Because what is called as an opportunistic infection? This is an infection which occurs when the patient is immunocompromised, when the immunity of the patient is otherwise low. Okay, because of any other systemic condition like HIV or stress or smoking, likewise. So this particular condition occurs in patients who have a lower immunity, okay, who are immunocompromised. And clinically, it starts, the incidence, it starts with the tip of the interdental papilla. And if not treated, it continues to involve the whole of papilla, then the gingival crest, the marginal gingiva, and then to attach gingiva, and then further down and down. Okay. So to the mucosal areas also, and can cause a periodontal distraction, entire periodontal distraction. And this particular infection is transmissible, or it is, but it is not communicable. What do you mean by that particular sentence? Okay, that means a disease, when it is said to be transmissible, it means that this disease has got a causative organism, a bacteria, and when the bacteria is isolated from an infected person and introduced into a healthy person, then it causes the disease. You have to recollect the Cox postulates for understanding that. Okay. So this is a transmissible disease, but it's not contagious, means, or communicable. That means it doesn't spread from one person to another through droplets or through other, liquid forms. Okay. And you should also know the other terminologies associated with it, because sometimes this word ANUG or NUG will be replaced by these terminologies and can come in the examination. So you shouldn't, go blank. So it is also called as Vincent stomatitis, trench mouth, or putrid stomatitis because of the bad smell that comes out when the patient is infected. Okay. And clinically, I've already told you, it starts with the at the tip of the interdental papilla, but there is a characteristic appearance for this lesion, that is, it will be appearing as punched out crater-like depressions. So whenever the terminology is like punched out crater-like depressions, then you can just blankly say like, okay, this is a question pertaining to ANUG or necrotizing ulcerative periodontitis. So it starts with the interdental papilla and then it can progress to the marginal gingiva also, most commonly. And if left untreated, it further progresses down into the attached gingiva and then the mucosal areas. And most generally, it is covered by a pseudomembrane, which can be easily pulled off, but it bleeds spontaneously. Okay. That means without any pain, that membrane can be pulled off, but it can bleed spontaneously while doing so. And there are also other features apart from these clinical features, like the patient can say like metallic taste, or you can see fetid, very bad smell that would emanate from the oral cavity. And there are also, it can show systemic involvement like lymphadenopathy, fever, malaise, and also sometimes increased salivation too. Okay, so these are the various features characteristic to ANUG. And regarding this particular slide, you'll all have to by heart, because always question one or more questions have been asked from this particular portion. Okay. That means who has given out the staging of NUG? Okay. It is Horning and Cohen. Asked as a question. So the stage one, I've been repeatedly telling this. Hope I'm audible. Just a second. Okay. So I'm repeatedly telling this because that important is this, so that at least without reading further, this will get retained in your mind. Okay. So stage one, it is the tip of interdental papilla. Stage two, the entire papilla is involved, necrosis of the entire papilla. And the third stage is when it involves the gingival margin. And the fourth stage, when the attached gingiva is also involved. And fifth is the one when it extends to the mucosa. And sixth, when it exposes the alveolar bone, and seventh, when it perforates the skin of the cheek. Okay. So then the last stage, when it perforates the skin of the cheek, then just so this particular slide, you have to be thorough with. Okay. And with regard to necrotizing ulcerated gingivitis or periodontitis, one another characteristic thing which you have to, always be there in your mind is that in this particular condition, it can cause periodontal distraction, it can cause complete periodontal breakdown also if left untreated. But there will be no pocket formation in this particular condition. Why? Because what is pocket? Pocket means it is a pathologic deepening of the sulcus, right? So for that you have, which has a gingiva on the one side and tooth on the other side. So it should have that gingival tissue, right, for the pocket to form. But in necrotizing ulcerated gingivitis or periodontal form, it is the necrosis of the tissues that is being happening, right? So there is no tissue that is left to, pathologically deepen. So there is no pocket formation absolutely in this particular condition, but there will be distraction of periodontium. Okay. And from the examination point of view, one another thing which you have to have in mind is the zones. Okay. When it was put forward by Mr. Garten, and when he examined the zones, when I say about the zones, it is nothing but when the gingival tissue, which is infected with this particular form of infection, that is this necrotizing ulcerated gingivitis or periodontitis, when this is viewed under the microscope, Mr. Garten could find out that it was exhibited in 4 different zones. Okay. Where zone 1 is a bacterial zone, which is the most superficial zone, and zone 2 is a neutrophil rich zone. Whenever there is a bacterial infection, our neutrophils will come into action, right? So the second zone is a neutrophil rich zone, and the third zone is a necrotic zone. Already necrosis has happened. And the fourth zone is a zone of spirochetal infiltration. Only the spirochetes are there, because they are very motile organisms and they have a high depth of penetration. So that zone 4 is there with spirochetal infiltration. Now coming on to the treatment of NUG. Okay. First and foremost treatment, when a patient presents to you with NUG, oral prophylaxis, it has to be done. And then that area has to be debrided with 3% hydrogen peroxide and with equal dilution of water. And the patient also has to be advocated to carry on with the debridement with 3% hydrogen peroxide, like for 3 to 4 days. Excuse me. Yeah. So for 3 to 4 days, you will have to ask the patient to continue with this debridement. And then you have to recall the patient. Like when you recall the patient, like after 3 to 4 days, there will be almost the active lesion would have subsided, but then there will be the sponged out crater-like depressions that will be seen. So that has to be corrected by gingivoplasty, because otherwise this crater-like depressions would form as a need us for the further food accumulation, food lodgement, and then the hygiene will not be able to be maintained for the patient. So only after the active lesion has been subsided, this gingivoplasty has to be done. And then you have to recall the patient after 1 month, that is 4 weeks time, for any further treatment, like for the periodontal distraction that might have happened, like extraction or any other periodontal therapy. So the first one is oral prophylaxis, then the debridement with 3% hydrogen peroxide with equal dilution of water. And then in the next visit, gingivoplasty. Also, you have to recall the patient for further periodontal therapy. Antibiotics, okay, it is prescribed only if there is a systemic involvement, not otherwise. Okay. And when the patient has systemic involvement, like lymphadenopathy, fever, malaise, etc., then you have to prescribe antibiotics. And amoxicillin is the drug of choice. Amoxicillin, 500 mg, 6 hourly for 10 days is the drug of choice. But for those who have allergy to amoxicillin, then the second drug of choice is metronidazole, and also erythromycin can be given for the patient. So this question, drug regimen of choice in ANAG is amoxicillin. So by now I have told you the answer. It is amoxicillin 500 mg 6 hourly for 10 days. And these are also, please take into note the dosage and the number of days for if amoxicillin sensitive patients. That is erythromycin and metronidazole, both are of 500 mg, but erythromycin is given every 6 hours, like amoxicillin. Okay, and but metronidazole, if it is given twice daily for 7 days. Okay, and erythromycin is also given for 7 days only. Okay, so this dosage and the number of days, it's very important, because sometimes instead of this question, a question can be asked like drug regimen of choice in NUG for penicillin for patients who are sensitive to amoxicillin. Then you have to know about the dosage. Okay. If it is metronidazole 200 mg BD for 10 days, metronidazole 500 mg BD for 10 days. So this is being like the changes can be with the dosage and the number of days. So you should know what exact dosage for how many days has to be prescribed. So it is 500 mg BD for 7 days. Okay. Now the next question is, which among the following is true for, which is the true statement? So it is uncommon in children, which is actually true. Okay. The second one, so but you just go through the next ones also. Immunity develops after the acute episodes. Okay, there is no study which proves that there is an immunity that has been developing. There's a pure bacterial infection, which is an acute infection, but no immunity there is. In fact, it occurs in immunocompromised patients. So this is false. And then does not have any specific duration. Like it actually resolves in 3 to 4 days if treatment is given. Okay. And the fourth option is contagion. Contagion means contagious is like I've already told you, it's not contagious, but it is transmissible, but not contagious. Okay, so the answer to this is the first one, uncommon in children. So there is another lesion, another infection, which is very common, which resembles a nug in many of the clinical presentation, which is common in children. Okay, so what is it? So that is herpetic gingivostomatitis, which has the positive organism itself is different. It is a viral infection. And since it's a viral infection, so a little bit I'll tell about this herpetic gingivostomatitis also, because many times the questions, might involve options from this particular portion. So you should not get confused. Okay. So the features that are similar to in herpetic gingivostomatitis is that there can be a systemic involvement. Okay. That means fever, malaise, lymphadenopathy. And clinically, there can be fetal odor from the oral cavity. But the lesion presentation itself is different. There will be vesicles and that will rupture to give an eroded appearance in the oral cavity, and the patient will say that they have pain. Okay, and this particular condition commonly is seen in preschoolers and children. Okay, and this is a viral infection And since it's a viral infection, it subsides on its own most generally like in 7 to 10 days. Okay. Only if there is a systemic involvement, again, that you will have to give that palliative care and antibiotics and ask the patient to drink lots of water. That those palliative type of treatment is really advocated for this particular condition. Okay. Now the next is mark the true statement. Desquamative gingivitis involve marginal gingiva and anug has widespread oral involvement. Okay. And second option is anug involve marginal gingiva and desquamative gingivitis has widespread oral involvement. And the third option, both involve the entire oral cavity. Fourth is both involve the marginal gingiva. So for this, you have to know what is desquamative gingivitis and how it is presented clinically, right? So the answer to this question is, so I've already told you, Anak, it starts with the papilla and the crest of marginal gingiva, and only if it is left untreated, that it progresses further down. But desquamative gingivitis, it has no specific location of incidence or anything like that. Like it can occur anywhere in the oral cavity, masticatory mucosa, or even the lining mucosa. Okay. So desquamative gingivitis, actually, it is an autoimmune disease. There is no specific causative organism for it. But most commonly what happens is because of the lesions, because patient will have pain and burning sensation, mostly in desquamative gingivitis. There will be patches of erythema that can be seen in the masticatory mucosa and other parts of the oral cavity. And because of the discomfort, the patient might compromise brushing and oral hygiene practices, and as a result of which, opportunistic bacterial infections can occur in desquamative gingivitis. But otherwise, it is not caused by any organism. It's an autoimmune disease. Okay, and it is most commonly seen in adults also, and it can occur. It can have a widespread oral involvement. Okay. So that is the answer for that. So with that, our first topic, that is anug, is over. As I've told you, this is a very small topic, easy to be read and understood and recollected. So hope you all have got an idea about the same and what all questions can be asked from that particular portion. So now our second topic of discussion is splinting. Okay, splinting also clinically, this is very easy to be understood and you all might be knowing. So it's just like brushing up. So what is splinting actually? What for periodontal splinting specifically when we say, it is the procedure of choice when the patient comes to you with a complaint that my teeth are mobile, right? So basically, when you speak about splinting, it is actually joining of two or more body parts which are mobile with a rigid unit. And so that rigid device or unit with which this is being joined is called as a splint. So periodontal splint is when two or more mobile teeth are joined together with the rigid unit. And so based on the type of the material being used for joining the mobile teeth, there are different classifications, okay, which we will be discussing. So basically, splinting is to stabilize the mobile teeth. And so what are the objectives? What are we trying to get through splinting? Okay, splinting is done to provide rest and support to the mobile teeth, first of all, and also to redirect and redistribute the forces equally. Okay, because among all the teeth. And this while doing splinting, it preserves the arch integrity also, and it restores the functional stability so that it restores the psychological well-being of the patient. Otherwise, when the teeth is mobile, it's very difficult for speech, it's difficult for having food. So it altogether, and if it is clearly visible when you smile, then it is further of a confidence issue. So everything is restored, while doing splinting. Okay, the arch is preserved, the function is maintained, and also aesthetically also it gives a better result. And so it is to stabilize a mobile. And apart from this basic, things, splinting is also done temporarily in cases where the teeth is mobile and we are proceeding with the periodontal surgery. Because sometimes the teeth will be in the verge, like that will be grade 3.
टॉपिक का करना तो कंपलसरी है कि नहीं
Excuse me.
क्या 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 मैम
Some
चांदी को जो ये पेपर मिला है ना वो
somebody, can
नहीं है।
you please?
भाई हम लोग को भी मिला है, लेकिन मुझे ये जानना है कि वो कंपलसरी।
Okay. Yeah. So sorry for that interruption. Yeah. Uh, so the other things where you will have to think about, like when the patient comes to you with a grade 2 mobility, and you will have to proceed with a periodontal surgery. But then, when we open the flap and do the procedure, sometimes that mobility always increases after surgery. So that grade 2 mobility can become grade 3, and even it can result in loss of teeth. Sometimes we need to stabilize the teeth for some time, like to promote healing. So in such cases, also temporary or provisional splinting is being done. Okay, and also to prevent the eruption of teeth which does not have an opposing teeth or an antagonist. That case also we do splinting. Okay, and so what type of splint, like when we do the procedure, when is it that we call it as an ideal splint? Okay, so first of all, an ideal splint means it should be simple in design, okay, easily fabricated without much time consumption. And one of the major factors, it should be hygienic. Okay, it shouldn't it shouldn't cause further plaque accumulation, which would lead to further periodontal breakdown. Okay, so it should be an easily glanceable one and stable and efficient without irritating or interfering with other tissues or your mastication. And, it should be finally aesthetic and economic. Okay, these are the factors which makes the splint an ideal one. Okay, and again, coming on to the indications and contraindications, that means like when do you uh, prefer to splint, or when do you think of splinting? Okay, when a case is presented. Okay, in case of moderate to advanced tooth mobility, but in that case, with even when you after you do an occlusal adjustment, that is when the cause of this tooth mobility is secondary trauma from occlusion, or like when it is not primary trauma from occlusion, the mobility is not because of primary trauma from occlusion, that is when you have to consider the splinting. Okay, when the case is primary trauma from occlusion, like sometimes what happens means the periodontium will be intact, but because of some traumatic occlusion, the tooth would be mobile. So in such cases, the first thing you should go for is not splinting, but occlusal correction. That is what is meant by that. Okay, so the first indication is moderate to advanced tooth mobility that can't be reduced by other means like occlusal adjustment. And then you do splinting to facilitate scaling and for surgical procedures. I've already discussed, because when the tooth is mobile, shaky, then like you will not be able to even clean the adjacent tooth properly, right? So for that scaling procedure or surgical procedure, temporary splinting or provisional splinting can be done. And also to stabilize the teeth after orthodontic movement, where we use a retainers. Okay, so that is it. And in cases of dental traumas like subluxations where or avulsions where tooth comes out from the socket, so for a while to stabilize the tooth in the socket, we do splitting. And as I've already discussed, it is to prevent the extrusion of teeth in cases where it doesn't have an antagonist tooth. So while discussing the indications itself, I have told you the major contraindication. That means the major contraindication where people wrongly do splinting is that there might be minor mobility, tooth mobility, or maybe greater tooth mobility because of severe traumatic occlusion. In such cases, first thing you have to do is the correction of occlusion and then wait for some time to see if the mobility is subsiding. And only after that, splinting is indicated. And also, this is contraindicated in cases where there is no adequate number of teeth to gain support from. Okay, that case also it is contraindicated. And also, if the patient is not maintaining oral hygiene well, and if the patient has got high caries activity, such cases also the splitting is not indicated because it would cause further periodontal breakdown. It would only give a very temporary relief for the patient. Okay. And coming on to the classification, I've already told you, depending on the period of stabilization, there can be permanent splinting and temporary and provisional splinting. And depending on the type of material, they can be composite, acrylic, wire, like that, different types are there. And according to the location of the intracoronal and extracoronal outside the teeth surface, and also you can prepare the teeth a little bit and just embed the wire uh, or maybe whatever splint that is being used, okay, into the tooth surface, not the surface, into the tooth. So that is what is intracoronal. So it is nothing but the names itself has suggested, each one in detail. Period of stabilization temporary when it is worn less than 6 months. Provisional, it is for a temporary period. Like I have told you, in case of surgeries, like when you do, like once after the healing period is over, we might take it off. That is provisional. And permanent is one which is worn infinitely. Okay. And then depending on the type of material, you have the composite one and the wire, then the A splints, the acrylic splints. So these are the various ones, and then the location, intracoronal and extracoronal ones. Okay. So, and the newer advancement in splinting is a fiber mesh. Okay, that is the most commonly used splint now because of two or three reasons. That is, first of all, because of the ease of placement. Secondly, because it's very stable and fracture resistant. It doesn't come out from the teeth very that easily. Okay, once it is light cured and etched and bonded and cured. Okay, and second is because of its aesthetic appearance, because it gives a white color, so it aesthetically also it is very pleasing. So because of these reasons, this is the most commonly used one nowadays. And we'll come on to the procedure by which it is done. So to do it, to do splinting, we should know certain principles, okay, that has to be incorporated when we do the procedure of splinting. What are they? Like, first of all, we should decide how many teeth to be included in the splinting. Okay. It is said that the root surface area of the healthy teeth should be double than that of the mobile teeth. Okay, so that many number of teeth has to be included when you do splinting. Okay, and then the splinting should be done in such a way that it should be around the arch ideally. That means, an arch is can be divided into two posterior segment and one anterior segment, right? So ideally, what happens, you should involve few teeth from, if the mobility is with the anterior segment, you should involve few teeth from the posterior segment also. So that arch doesn't collapse. Okay, the splinted portion doesn't collapse. So that should be the ideal way. But usually, always we do splinting in the relation to anterior teeth, right? So inclusion of canine teeth, if it is adequately strong enough, that would serve the purpose because that is a corner teeth. Okay, and then it should not interfere with the occlusion. That also should be checked before you place a wire or whatever the fiber mesh or anything. Like, it should not interfere with occlusion once after splinting, and should facilitate adequate plaque control, and it should be aesthetically acceptable also. And splinting, as I've already told you, should be done only after coronoplasty or occlusal correction if it is indicated. Okay. And coming on to the procedure, first, adequate length of the wire or the fiber mesh has to be taken and cut. And for measuring the length of how much should be taken, you can use a periodontal probe or a dental floss also. And then clean the surface of the teeth where the splinting has to be done, and with the ultrasonic scaler, as well as thoroughly polish and clean that area. Also, you can just roughly make the surface rough by moving the burr a little bit without causing any distraction. And then if it is you have to place the wedge in between the embrasure spaces, that's the interdental spaces, to prevent the flow of the composite material into the embrasure space, and because otherwise it would irritate the gums, and also that would serve as a niche for the plaque accumulation. Okay, it is for the the area for plaque accumulation. Okay. And if not wedges used, you should be very careful that that area is not filled with the composite. And then acid etching, like you do a composite restoration. First, you have to do for acid etching, and then that you're doing it on enamel. So etching should be done. 37% phosphoric acid is to be applied, and then wait, with the applicator tip, and wait for 30 seconds, and then rinse with water and dry it, so that you will get a white frosty appearance. So that means you have etched the surface properly. And then a bonding agent has to be applied, and then that surface is being cured. And then with the help of a hand instrument, the first you have to place a layer of flowable composite, and then this fiber mesh is placed. And with a hand instrument, it is adapted well, and tooth by tooth, each tooth has to be cured. And when you cure each tooth, you will have to apply a little bit of molding agent on top of this fiber mesh also, so that it is adequately, it is made further strong and stable. Okay. So, and then final finishing and polishing and everything is being done. And then evaluate occlusion, that it does not interfere with the occlusion. So this is how it is being done. That is not very relevant from the MCQ question point of view. I'll also tell you the area from which you can expect questions in with regard to this particular portion. Okay, now the advantages and disadvantages. So if you have understood what is plating and when can it be done and the whole procedure, you yourself will be knowing what are the advantages, what are the disadvantages. What are the advantages? It stabilizes the tooth, right? It decreases the mobility, it stabilizes the tooth, so patient well-being, it improves the patient well-being, functional stability, and then it can be used for regenerative therapies and also for proper scaling, even for proper scaling. And in cases of in dental traumas where you have lost your teeth, and you can just put it back, and in case of avulsion and subluxation, even you can try splinting. So these are the advantages, and it promotes healing even after the surgery. Okay, so these are the advantages. But the disadvantages are the technical difficulty. You will not be able to do it yourself. You need an assistant for the procedure. And splinting, if not properly done, it hampers patient self-care, and it would pave way for further periodontal breakdown, and chances of developing caries are also more. And if not properly done, it can cause a destruction of the entire, teeth which has been splinted. The entire unit, the splint unit, can become periodontally destroyed because of the uneven distribution of the forces. Okay. So this is a question. Mostly questions can be coming from indications, contraindications, and also this advantages and disadvantages part in case of splitting. Also, you should be able to identify each type of split, and also from the theoretical point of view, each type of split based on the duration, temporary, provisional, and permanent. Okay, so these are the areas from which questions can be asked. So, for example, in which case splitting is contraindicated? So, those of you who know the answer can give it in the comment box so that I can understand that you all have understood the concept well. So, in which case this splinting is contraindicated? Cases of moderate to advanced tooth mobility, cases of tooth mobility where primary reason is trauma from occlusion, cases of advanced tooth mobility due to secondary trauma from occlusion to stabilize teeth prior to surgical procedure. So, which case do you think it is contraindicated? Anybody, can you give the answer? Yeah. So it is I've already told you, in case where the tooth mobility has a primary reason of the tooth mobility is traumatic occlusion. It is that case. Somebody else. Yeah, correct. Correct, Raj. It is the second option. That is cases of tooth mobility where the primary reason is trauma from occlusion. Whenever there is traumatic occlusion first diagnosed for the reason for the tooth mobility, then you have to always go for occlusal correction. But it is only in cases where clinically, if you're seeing such a patient, if the mobility is like great, 2 or verge of 3 and all that, you will have to go for splinting itself to promote healing, but after occlusal correction. Okay. So with that, actually, we have come to the end of the presentation because it was 2 small topics. If anybody has any doubt pertaining to this, you can just type in the comment box now. So, anybody? Do you have any doubts? Or can we end the session? So, since it was very small topic, like we could end the session very easily, like fastly. If you have any doubt, you can just give it in the comment box so that I'll be happy to answer. Okay. So in case you have any doubt, you are free to contact me. So not with related to this topic, but also with regard to any topic in perio. Okay, thank you so much.